Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of FFS-For Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hi, friends, and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and I'm just so excited to have you here today. I've got to admit, this episode is coming off of returning from ASRM, which is our national meeting, the American Society for Reproductive Medicine. ASRM is this huge event. I remember the first time I went, I was a resident, so I was in my OBGYN training, and I really wanted to do REI. You may not know that REI is a field that is really hard to get into. There's very few spots. It's actually a huge problem, but there's only about 40 to 50 spots per year, depending on the year. And so going and presenting research at ASRM is a really big deal. So I was a resident, and I used to work L&D, so I'd be on Parkland. The L&Ds there crazy all night long. And then I would go after my night shift was done at 7 a.m., to the lab. And I had the most fabulous mentor. Her name was Lisa Halverson, and she studied pituitary hormones. And she had this basic science lab, and I knew nothing. I knew nothing about basic science. But I would go sit in that lab for hours every day, and I would pipette cells, and I would culture out these pituitary cells and run these experiments. And I remember the day my cells died, crying over it, because it just felt like such this investment to get them to grow, and then they died. But the point really was to learn so much about the endocrine system, and I dedicated so much time. So going to ASRM as this resident who really wanted to go into the field, I was so excited, and I was presenting my research, and it was just this huge validating moment of I want to be in this field. These people are so smart. I love the tech and the science, and being able to connect with so many people who are like-minded across the country is just incredible. So I've been fortunate enough to go to ASRM many times now, especially since I've been out of training so long. And I was giving some talks. I led an advocacy workshop, and you all know that a lot of my work now is about social media and advocacy and patient care. I got a master's of science in clinical research, so I have a long history of research projects and clinical research and epidemiology, published a lot in fellowship, but ultimately, I love taking care of patients and you guys. But being at ASRM never ceases to re-inspire me, and so many people, even within my field, who know about this podcast and come up to me, people who want to talk about it and thank me for it and make me, it's really crazy. I never really anticipated any of this, and I'm in my bedroom right now recording, so sometimes you get such this isolated view. I record it here, I put it out in the world, and it just means a lot when you guys take the time to come up and introduce yourself and say how much this means. So a huge thank you to all of those people. You know who you are. What I want to talk about today is something very interesting, because when you're at ASRM, there's this huge expo hall, and there are so many people who are here from industry. So one of the things I love about the fertility world is, well, one, hormones, like it's so nerdy and I love it, but also the science. The science is so cool, so incredible, and constantly changing. One of the hardest things is that science has changed. Meaning, in the olden days, people would have an idea, they would do a study to see if it worked, and the studies were non-biased. And then if it worked, this thing would be introduced into the field as a medicine, a technology, etc. We'll say in basic medicine or basic science. IVF has always lived on the fringe. Let's imagine an IRB approval that would say, yeah, you can go in and put eggs and sperm together and just see what happens. And so IVF has always lived on the boundaries of pushing what's okay and advancing the science by doing versus studying. And I know that sounds crazy, but it's really, really true. Where we are now, though, is there is a flux of money and interest from industry, private equity into the space. And with that are goods and bads. We're just going to lay it on the table, meaning people who have money see an opportunity to make money. On the tech side, they are trying to make tests and equipment and rolling them out, funding their own studies, inherently having bias, and introducing them. On the science side, we often don't know how to interpret some of these things to the general population or to all of the people that we treat. And often the study that comes much later might say something different when it's truly done in a scientific fashion. So a company has an idea, they make it, they fund their own study, they get results they want, they don't release the results that don't support their study, and then suddenly this product or offering is out there. Everybody wants you to do this test or do this thing because we get it. We're so desperate for success, and I promise we are too. But there's this idea that sometimes more is more, and not that more might be harmful. And that's really what we have to start thinking about. So let's use an example of the ERA test. So the ERA test is an endometrial receptivity analysis test. One thing that has plagued us in this field for a very long time is that we do not have 100% success rates. And we don't. If anybody tells you they have 90%, 100% success rates, one, they are lying. Two, they are probably not a SART member. They are reporting some off-fringe number. Because the reality is, every embryo is not going to make a baby. There is still a lot left to learn. If we rewind the clock a little bit to before we had PGT testing. So PGT is pre-implantation genetic testing. So this is where you take a biopsy of some cells of the embryo and you test the genetics of the embryo. So PGT really became more mainstream in the past 10 to 12 years. Before that, it wasn't really done very much. So before this, we had embryos. You would judge how pretty they were under the microscope. You would put 1 to 4 inside a person depending on their age, because we knew that the percentage of normal embryos decreased as you got older, success rates decreased, and a lot of transfers didn't work. You also had lots of multiples, and you really saw not the best outcomes ultimately from the cycles. PGT itself has come a long way as well. So embryo transfers also used to happen at day 3, where embryos are 6 to 8 cells, and you would take out an entire cell from that early stage, which had a lot of risk of damage to the embryo. Well, once technology improved and culture media improved and we could grow embryos to the blastocyst stage, or day 5 or 6, where they could be implanted, this overcame some of those issues. So that's fantastic. Now you could grow embryos to the blastocyst stage in the lab, which ultimately is a great environment. People will argue about this and say the body is more natural and we should put day 2 or 3 embryos back in the body because it's the perfect incubator. And my argument is this: for the vast majority of our patients, they are not getting pregnant, and very often we don't always know why. And I believe, and y'all know this, inflammation and the state of the body is a big component. So riddle me why in a person with long-standing unexplained infertility, I now suddenly think putting embryos back into that environment and letting them incubate, keep growing inside the uterine cavity is 1, appropriate, or 2, going to result in a superior outcome. Further supporting this is that that's not physiologically what happens. Egg and sperm meet in the fallopian tube. We know that the egg only lives for 24 hours. The little sperm has to come up and fertilize, and then that embryo has to make its way into the uterine cavity. So early embryo growth and development, the culture of embryos in the body, happens in the fallopian tube, not the uterus. The embryo arrives in the uterus the day 5 or 6 stage. All of this to be said, there are still practices out there who don't do genetic testing, who believe in transferring day 2 or 3 embryos and shoving a bunch of them in the body. And to me, I'm not a fan. If the lab is the perfect environment at the right temperature and pH and no toxins and no inflammation, and our embryos can't get to the blastocyst stage, then I do not believe they will get to it in the body. So embryo culture improved. We're able to grow out embryos. PGT has improved a crazy amount. Now we can biopsy embryos from the trophoblast, which is the placental segment, and the embryos at this stage are 200 to 300 cells. They're expanded, and then you're able to run that test. And so now, with much, much, much lower risk of harm, you're able to biopsy and freeze an embryo with nearly always no impact, meaning no damage from the biopsy and no failed survival. People will quote you a 1% to 2% risk of failure of thaw after the freeze, but in clinical practice, it's so much lower than that. Okay, so genetic testing comes around. We now know which embryos are genetically normal because before this, we blamed everything on the embryo, 100% of everything. Well, I'm so sorry it didn't work. Embryo must not have been normal. Let's do it again. Boom, suddenly normal embryos. So now we're in a place where we have euploid embryos. And yes, PGT testing is not perfect, even with a trophoblast biopsy, but it's very good. Recent studies show that it's even more sensitive than NIPT testing, which is the testing that you do when you're already pregnant. So this is very good testing. That said, why is the live birth rate with genetically normal embryos nationally about 60%? Okay, that's so good. It really is. If we think about your monthly pregnancy rate from just ovulating, having intercourse, at best, that number tends to be 20 to 25 if you're under age 30, and then it only decreases so that a 40-year-old is going to have about a 5% chance of pregnancy per month. If we do IVF and I get a genetically normal embryo and I transfer it, I have national average 60% chance of a live birth. So I have improved your efficiency and your opportunity for conception immensely. Granted, at age 40, more of your embryos are going to be genetically abnormal and you're going to have less eggs. So finding a genetically normal embryo may not be as easy as it sounds. If the average egg count at age 40 is 8 to 10, and about 20 to 25% of your embryos may be genetically normal. But by no means is it usually impossible, and setting the road for expectation is important. That said, why is it not higher? That's a very interesting concept, and this is what the ERA test came to challenge. So the ERA test said, hey, if it's not the embryo, it's the uterus. So in all these other people, there must be a problem with the uterus. The uterus must not be receptive. What does that mean, receptive? So if we think about what happens naturally in the body, after you ovulate, that follicle where the egg grew starts to make progesterone. We know this is called the corpus luteum and stimulated by LH pulses from the brain. So you now have a corpus luteum making progesterone. Progesterone is essential for implantation and for receptivity of the uterus. Progesterone changes the lining of the uterus. The lining goes from what we call proliferative to secretory. It starts to compact and it prepares itself to allow an embryo to implant. We know that progesterone opens and closes the implantation window. However, the ERA test works under the premise that the progesterone window for implantation is probably much smaller than we really believe that it is. Most people believe that the implantation window spans really about a 3-day window. Remember that in natural cycles, progesterone is rising and falling based on LH pulses from the brain. And so this idea of the ERA test, which the ERA test is trying to look at the gene profile of the endometrium, essentially we'll simplify it and say expression of estrogen progesterone receptors in that gene profile to see if it fits their definition of perfect implantation window timing. Interestingly, when we look at this, most studies, so without the ERA test, but most studies when you manipulate progesterone have actually not shown a difference by about a 24-hour swing. And in fact, clinics do different things. And when you look at these modified natural transfers, when people are starting to surge naturally and make progesterone naturally, people do a lot of different things. And so if we think, and that there's literature saying 12 to 24 hours difference of progesterone start really has not been proven to make any difference in pregnancy rates, what is this test showing us? Another thing we know is that this test, or any endometrial histology or genetic expression, is so dependent on the hormonal environment that precedes it. So the exact estrogen levels, the exact progesterone levels. This poses another issue because no two cycles are the same. Even if you use the same medications, there are so many factors that go into your body when it comes to manipulation of the hormones. And then we see people doing the ERA test off of natural cycles or modified natural cycles, which is completely non-replicatable. And then you see people doing it in one and doing a different transfer type. So we lose the premise of the test when we go and switch the protocol. So even how people clinically practice with this test is crazy sauce. So for this test, you do an entire mock cycle of some way you get the lining to what you think is the right time for implantation, and you do a biopsy of the endometrium. This biopsy has to be done at a set time. You tell them when progesterone started. It does have a risk of getting a non-informative result. And for most people, this has taken 4 to 6 weeks to get here. So you can decrease the chance of a non-informative by doing 2 biopsies. Then you're going to have a period and get restarted in a transfer cycle once results return. So number 1, endometrial biopsies are not fun. Number 2, this test costs money, it's not cheap. And number 3, this takes time. So is it worth spending money, time, and pain if it doesn't make a difference? This has been the argument for a long time, with a lot of people saying, well, it'll be worth it to me if the data changes my outcome. And we'll get back to that. So the idea of this test is to say, hey, if it's not the embryo, y'all are only living at 60%, it must be the uterus. And so we are going to roll out a test showing that we can modify the receptivity of the uterine environment by changing the window of when you start progesterone to when you do the transfer. Okay, so we're trying to find reasons why embryos don't implant, and this is frustrating for patient and for doctor, not denying that recurrent implantation failure is a real thing. The original study about the ERA test was published in 2013. It had 85 patients with recurrent implantation failure, so they said, and 25 control patients. In this study, they said the ERA gave a receptive result in 74% of the implantation failure patients and 88% of control subjects. Follow-up was only possible in 29 of the recurrent patients. And when they did the personalized embryo transfer, meaning adjusting it based on what the ERA said. So also remember, this was only a small group, right? Because 74% were actually receptive. So in the other group where they went into this personalized, they saw a 51% pregnancy rate. A couple issues with this is that these are small numbers, a small group, but also these weren't genetically tested embryos, and they took people who were up to age 40. So that's a huge limitation just right there. There was a subsequent randomized controlled trial that came out. It had 50% of patients dropping out, and it promotes a higher pregnancy rate with the personalized FET. However, when you really looked at it, live birth rates with that first transfer afterward were not statistically different in the personalized embryo transfer and the frozen embryo transfer per standard. I think that's really important. All of this information led to the claim that 25% of failed IVF cycles were due to endometrial problems. And this has not been supported by studies overall. And we have to remember that some of the best data we have still supports the fact that even in genetically normal embryos, there is something about embryo competency that really contributes And that makes sense, right? If we think about genetic normalcy being the low end of the totem pole, the minimum required, the embryo needs to have appropriate metabolism. Cells have to divide, has to form to organs, to a baby. That is a lot more than just genetics. Our best data in euploid embryos. So if we now look at genetically normal embryos, remember the ERA data set is not historically genetically normal embryos. We do a single embryo transfer and we change nothing about the protocol. Not the type of meds, not the duration of progesterone exposure. The cumulative pregnancy rate after 3 euploid transfers is 95%. That means that only 5% of people really get the definition of recurrent implantation failure and potentially could benefit when we are intervening on this test for people who have only one embryo or who have failed one transfer. There has been a huge push and a request to do this, and it has been done over and over. There are clinics that I know in my town who require patients to do an ERA test before their first transfer, no matter what. And when we look out the newest studies that have come out in the past few years, reviewing the human endometrium shows inconsistently reported differentially expressed genes. We know this. Histology has been unproven to be reflective of timing or dating for luteal phase defect because things change cycle to cycle. Same thing happens with the human endometrium. So then we saw a study published in Fertility and Sterility in 2022 showing that live birth rate after a single euploid frozen transfer, according to standard timing versus recommended by ERA, that there was no difference in pregnancy rates or outcomes. And in this group, they had people who hadn't even failed FETs looking at it. And what was crazy, that of the patients who had an ERA, 60% came back non-receptive. There was no difference in people who had failed and not failed FETs. There was no difference in live birth rates. Really, this questioned if you should even do the ERA. Is that even a valid test if the majority of people come back abnormal? And the paper which came out last year, which really changed practice or should have changed practice, was published in Fertility and Sterility, and it's titled Use of the Endometrial Receptivity Array to Guide Personalized Embryo Transfer After a Failed Transfer Attempt was associated with a lower cumulative and per transfer live birth rate during both donor and autologous cycles. This study had over 3,000 cycles with your own eggs and 2,000 donor transfers. It looked at people who had one failed transfer. And what they looked at is they did the ERA and then they did the personalized embryo transfer, and they compared that to people who did not have the ERA test. And this study showed that after one failed transfer, the live birth rates across the board, whether it was a euploid embryo and even a non-euploid embryo, were lower in people who had an ERA test and changed their progesterone exposure. That group had a significantly lower live birth rate. And this finding held in subgroup analysis with PGT embryos, with embryos that weren't, with donor embryos, with autologous. The take-home message being that after one failed transfer, doing an ERA and then changing your transfer protocol or length of progesterone exposure based on that result had less of a chance of you bringing home a baby than just doing what we normally do. To put it simply, this test had harm when done in the wrong population. So we can sit here and say that especially in PGT-tested embryos, the rate of recurrent implantation failure is rare, meaning 3 failed euploid transfers. I have a really hard time giving somebody that diagnosis if they don't have genetically tested embryos. This is an issue in all of the literature that exists because other people don't feel like they have a hard time giving people that diagnosis. But if we are really wanting to blame it on the implantation process or the endometrium, that's actually a very low occurrence. The ERA test, when done in the wrong population, is not just something that you have spent more time, more money, an icky procedure, it actually now may lower your chance of succeeding. So this is a big deal. And I can't tell you how many patients after one failed transfer want to do this test. And I will admit, I have done it, especially before we had this data in the past 3 years, where it seemed like probably no harm, maybe benefit. And people were having this test done if they only had one embryo or after one failed transfer. This test, if it has benefit, is likely in the recurrent implantation failure group, and that is overall a small group. Does this pose a clinical conundrum for patients who do not have many embryos? Absolutely, absolutely. But part of your doctor's job is to judge risk of harm and risk of benefit, and trying to do the things that have the highest chance of getting you to your ultimate outcome. Please remember that more is better is not always an actual true statement. And that is the case with a lot of these, what we may call IVF add-ons, especially those add-ons that are backed by industry and people have a stake in making money off of them. I want you to have success. I want you to have so much success. I don't want to have the WTF talk with you after about why it failed, because often we don't know. But I will have it, of course, if it fails. Nobody wants to be in that position. So if there was a test that we really believed in, I have no problem making you spend more money, taking longer, or going through an invasive procedure if it was going to help us. Are you wrong to ask your clinic about this? No. Is your clinic wrong to do this test before you have ever had a transfer or before the first? That's not supported by the science that we have, and that may be lowering your odds of bringing a baby home. To me, this test has a place potentially in recurrent implantation failure, 3 euploid failed transfers, or in somebody with potentially an extensive history of recurrent pregnancy loss. We have to understand that science is always changing. Trying to bully your doctor into doing something is not going to be the right idea. But if your doctor also can't describe what I just did, and they say, we just don't do that test, without saying, we don't do that test because it's not valid, or we don't do that test in patients like you. Trust me, patients ask all the time for tests that exist, and I understand it's a desire to be educated and have data. I love data. If there's data to grab, I will grab it. But I only want data that's actually proven to be helpful, and certainly don't want to fall into the trap of doing stuff that could be harmful. So if you had an ERA test and you got pregnant, you may even be my patient, because science changes. That's part of being a good doctor. Doesn't mean that this test is the devil for everybody. But if we are looking at the people who exist right now, we are trying to make the best decision for you. If I were to use my crystal ball, then the future is going to say, look at what the embryo is putting out into the culture, and some of those factors might reflect its metabolism. And that's probably where the next era of trying to understand embryo competency is truly going to come from. I think a lot less is at the endometrial level for the majority of people than what we've given credit to in the past. We also have to remember that diseases like adenomyosis and endometriosis, they also change the endometrium, the blood supply. If you've had surgery of your uterus before, these are all unanswered questions, and a lot of these people are excluded from ERA studies. All right, well, that was a very lengthy discussion of one example of a fertility add-on, the ERA, or the Endometrial Receptivity Analysis test. I'm going to answer a few of your questions. These are questions that you submitted on Instagram on Monday at nataliecrawfordmd. These questions will get answered on Instagram in the newsletter, nataliecrawfordmd.com/newsletter, and here on the podcast in our For Fertility's Sake segment. You can also call and leave a message at 657-229-3672, 657-229-3672. I love answering your questions. Fertility Q&A episodes are my fave. Call and leave, and would love to answer those for you. I had to stop my IVF stimulation on day number 7 because of hyperstimulation. How can I help my body do better next time? Hyperstimulation is when you are on a protocol and your body starts to make too many eggs and your estrogen gets too high, and you are not on a protocol that is going to allow for a lupron-based trigger. So the protocol for a high responder should be an antagonist protocol. In this protocol, you can receive a Lupron trigger. Big asterisk or caveat is somebody who might have hypothalamic amenorrhea. They actually can't receive a Lupron trigger. They need HCG. So canceling cycles for hyperstim does happen. How can you help your body? One is understanding where you're coming from in this. Is it just random? But advocating for potentially a lower dose, potentially an overlap with medicine like letrozole, which can be a more mild stimulation. Advocating for a Lupron trigger if you do have periods, you don't have hypothalamic amenorrhea, say you're just PCOS with irregular periods, talk to your doctor about a Lupron-based trigger because you can ignore estrogen levels more. In patients with a high AMH and PCOS, even if they don't have insulin resistance, metformin has been shown to be helpful in decreasing the incidence of hyperstimulation. Overall, if you're just trying to heal your body, you have OHSS or anybody who might, when your estrogen gets really high, you start to third space the water portion of your blood vessels. So that water starts to move out of your blood vessels and it gets in your abdomen, it gets in your lungs. You can have a difficult time breathing. Your blood becomes thicker. This can result in kidney damage. This can also result in a higher chance of a blood clot. And that fluid that's inside your body can get infected and just overall be painful. So we take OHSS very seriously. Fluid deficits and electrolyte shifts are some of the big things. If you pass out, you feel dizzy, you're not mentating correctly, go to the doctor, go to the hospital. Some people do need acute electrolyte replacement. But typically for at-home management, what we're looking for is electrolyte replacement. This is the time where it is lean into Pedialyte and Gatorade. Try to have things that are salty. You probably will crave salt and just lean into it. That salt or that sodium actually helps attract water and can bring it back into the blood vessels. You also are going to want to not do any high impact exercise because your ovaries are going to be large. They can twist around and that can cause ovarian torsion, which is a subsequent problem. There are medications that can sometimes help speed up the recovery. These can be things like letrozole, ovulation blockers, antagonists, cabergoline, and getting on birth control pills earlier in the process to cut off the hormonal supply to these follicles. If you did not have a canceled cycle, don't get pregnant. Change your transfer, freeze your embryos. That's the number one thing you can do. You also should absolutely not have intercourse, especially if your cycle is canceled. High order multiple pregnancy, lots of badness can happen that way. OHSS has really become more rare because we have different protocols now. When it happens, it tends to be people who have a combination of PCOS with hypothalamic amenorrhea or people who are attempting to do a fresh embryo transfer, often in the guise of trying to save money. Sometimes saving money is just not the right answer. All right, next question is, I have my second retrieval coming up. I previously had 2 failed transfers. Suggestions to prepare for this cycle. Ultimately, I like people to switch their mentality and start working on preparing you and your body just to be your healthiest version of yourself. This includes sleep. Number 1, getting at least 7 hours of sleep. That's probably what most of my patients don't do that I wish that they would do. There is evidence that having a diet high in fruits and vegetables, whole grain carbohydrates, avoiding processed foods, processed meats, extra added sugars, we all know that that's better for us. Staying hydrated, trying to decrease stress, supplements like a prenatal vitamin, omega-3 fatty acids, and a CoQ10 supplement can also be helpful. Remember that more is not always more. I think that's like the message of this episode. But when it comes to supplements too, don't take too much biotin. It messes up your hormones. Don't take maca, ashwagandha, Vitex. No. Different herbs may be really cool and interesting, but they are not appropriate at this stage of the game, especially if they potentially interfere with hormone metabolism, and we are measuring your hormones to make clinical decisions. I also always just love a meeting with your doctor to review your protocol. Make sure that they have reviewed it, make any changes. Can they improve the number of mature eggs? Should they do something different trigger interval, different trigger size? Just make sure that you know that we're not just doing the same thing over and over. Ultimately, wishing you the best of luck. All data would support that you will get pregnant very, very soon. Can a D&C affect your chances of conceiving after? I'm not getting pregnant quickly like I did before. On the whole, no. A DNC procedure does not cause you to have a decrease in your fecundability or your chance of pregnancy. Rare complications can be not removing all retained products of conception. That can cause inflammation inside the uterus and potentially scarring. When this is severe, it's called Asherman, and you don't have a period, so that's a warning sign. But sometimes it can be mild, can impact implantation, and potentially you might have normal periods. So if it's really becoming a long time, definitely talk to your OB, consider seeing a fertility doctor. We also want to make sure that you know that pregnancy rates aren't super high. A lot of this depends on age. I certainly see people who get a positive pregnancy test and then it takes a long time. But if it is taking a while, this is where I am just always a fan of getting basic data so that you can make an educated decision. How often should we get blood work or a semen analysis, an AMH test done with our REI? Should this be a yearly thing? This is a really great question, and the truth is there's no current guidelines for this. Remember that both of these things, an AMH, an antral follicle count, or a semen analysis, these are one-time snapshots of the now. Neither of them predict that things will be fine in the future. So my question is, what are you going to do with the information? If you're getting it tested, you should be prepared to act. Meaning, if you're this invested in your fertility, I would really recommend that you consider freezing your eggs. If you have a partner who potentially has a medical problem, you could potentially freeze sperm. So things like diabetes, testosterone use, many things. Now, if you are just getting an evaluation done to get it done because you're trying to decide when to start your family, get it done. If you have abnormal results and you say, we'll start trying now, fantastic. But often remember that once you get those abnormal results, it is after the fact, and now it's going to be harder than when you had the normal results. So this is hard because we don't have good guidelines on it. Sperm are super fragile. They change every 3 months. They are very sensitive to environment. AMH and antral follicle count do have some monthly variation of about 30%. But if we look at it in categories of normal, then ultimately should not change much in a year. Once somebody has done an AMH test, I prefer follow-ups with an antral follicle count. And if it's in the range of normal, don't add much worry to it. Also remember that hormonal contraception can change AMH. It doesn't decrease your egg count, but it just suppresses the activity of the cells that make AMH. And this reverses when you're not utilizing that hormonal contraception. I always say if you're going to do something with the data, if it's going to be helpful to you, then that's a reason to get it checked. Just understand there's no real guidelines to how to interpret this in the long term. All right, friends, thank you so much for being here. As always, I just appreciate you so much as this podcast has grown. And again, a huge heartfelt thanks. You can leave your questions on Instagram, Mondays at nataliecrawfordmd, to be answered here on Instagram and in the newsletter, which you can sign up for, nataliecrawfordmd.com/newsletter. You also can leave your own voicemail at 657-229-3672. Those are my favorite episodes, and I can't wait to do more of them. Also, I just wanted to say we have the Enhance Your Natural Fertility and the IVF Guide, both self-study paced courses packed full of information, really in a gradual fashion to help you take control of your fertility journey. If you're doing fertility treatments, putting you in the place so that you can advocate for yourself. You can find more information about the courses on the website, nataliecrawfordmd.com. As always, thanks so much. Bye, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow FFS-For Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.